So I'll be talking a little bit about some of the newer advances in molecular diagnosis of infections in solid organ transplantation, and both the friendly and the foe aspects of these tests as we go about. As we know that I have nothing to disclose as such. I have used some brand names repeatedly over the presentation, but it's only to show that what is available, but I have nothing to disclose with these companies. I have used a few AI tools to prepare some of these slides. So this is the classical timeline of infections. As we know, it's very, very complex given the risk factors and the epidemiological affiliation that solid organ transplants have. So the typical infections in the early month are those that are derived from the donor sometimes and mostly from the hospital and as part of the surgery, the technical part of the surgery. In the first 6 months, in the 1 to 6 months, it is usually the reactivation of latent infections, several of these viruses that we spoke about a little earlier also, and some others. And more than 6 months, again, it's mostly the late reactivations. And an awareness of this pattern has, of course, led to use of prophylaxis. So we don't see exactly these infections that we did 20 years ago routinely, but there are newer emerging patterns that are more obvious. I think the best infection study that we have with a good follow-up is the Swiss transplant cohort study, and they included about 93% of all the solid organ transplants that were actually done in Switzerland, and they were followed up for at least a year. And what they found was that 55% of all SOT recipients experience an average of 1.3 infections at least in the first year itself. And what they see is that 63% of these infections are actually bacterial, and about 20%, 30% are viral, and very few fungal infections as such in SOT, which is probably a bigger problem in the hemat-onc setting. Among the bacterial infections, Enterobacteriaceae and Enterococcus species are the most common. And again, these are more common among the kidney transplant and the kidney pancreas transplant patients. In the fungi, again, for SOT, Candida is a bigger problem. Molds are probably less involved, especially except in lung transplants. And among the viral infections, they saw very little bit of CMV, about 1%. The others were all the other herpes viruses. Organ-wise, there is some differences in the kind of infections that were seen in this cohort. The lung transplants, of course, were associated with respiratory infections, both bacterial, fungal, and as well as viral. Whereas the kidney transplants were primarily urinary tract infections. Viruses caused all sorts of infections across the board, except for lung transplant, where it was mainly the respiratory tract infections. So there are several challenges with diagnosing infections in the solid organ transplant host. Apart from the immunosuppression per se, we do speak of the net state of immunosuppression, which includes factors of surgery, includes the donor-derived aspects, etc., which all contribute to the net state of immunosuppression. And because these patients may not classically have symptoms and radiological signs, the thought of getting the right diagnosis also is a challenge many of the times. And invasive specimens are difficult to get in these hosts. The pathogens can be extremely diverse, so we often have to cast a very wide net to find out what we may be looking for, and there may be breakthrough infections and overlapping signs on imaging. And the symptoms of infection often look like symptoms of rejection and toxicity, and therefore the conventional diagnostic tests, which generally suffer from higher turnaround times, especially in microbiology, are not really always useful, and we need advanced diagnostics which have speed. So the best friend that we are looking for is actually speed. So molecular diagnostics have resulted in a paradigm shift in solid organ transplant compared to where we were maybe 20 years ago. So the conventional techniques still are gold standard, culture, histopath, especially. Serology and antigen detection become less reliable because of the immunosuppression and the immune energy that is often seen. And there are suboptimal sensitivity and prolonged turnaround times that are a problem with this. Advanced diagnostics, broadly we categorize them into the multiplex molecular assays, which are PCR panels for simultaneous broad detection of various syndromes with or without AMR determinants. And the quantitative viral load monitoring, which we do especially for CMV, EBV, etc. Some of T-cell reactivity assays, which are relatively new, especially in the Indian setup, which assess pathogen-specific host immune responses. some fungal biomarkers which generally are subpar but are still useful to some extent in the SOT setting. And MNGS is an up-and-coming diagnostic modality for a completely agnostic, untargeted pathogen detection. So we'll start with what we use generally for the early infections and some of the multiplex panels. So if you look at the conventional way in which we diagnose bloodstream infections, for example, the patient comes in for a blood culture, they're sampled, the blood cultures are sent to the lab. This can take anywhere between 6 to 8 hours or even a day, depending on where the lab is located. The incubation can range anywhere between 6 to 120 hours for anything to flag positive. And once it flags positive, we do a subculture and wait for colonies to appear, which takes a further 6 to 18 hours. And once the colonies appear, we do an organism ID and AST, which can take a further of 12 to 14 hours. So all this can range from anywhere between 48 to 168 hours for you to get a final result of the blood cultures. There are several areas where you can intervene. The ideal thing that clinicians would generally want is something that you can directly send the blood sample without culturing and you can detect an organism. Unfortunately, we're not quite there yet. We don't have very many well-standardized and approved assays for this. Metagenomics is coming up in this aspect. There are a few tests that I will discuss later. But then they also suffer from specificity issues. Nucleic acid amplification tests like multiplex PCRs directly on the blood, there are several that are available, some from kits from Europe and several lab developed tests. Many of them again suffer from non-specificity and results can be misleading. Once the blood culture flags positive, however, we have the help of several technologies that can lead to an answer much faster than the conventional way. Malditop, for example, directly on the positively flagged bottles, you can have an ID, to say the least, within 6 hours of the flagging. There are microarray-based, nucleic acid amplification-based syndromic panels, like the BCID or BioFire that is available in India. Several others abroad, like the ePlex, Verigene, GenMark panels. Once we do have the colonies, of course, there are techniques like Malditop which can identify much earlier. And then there are rapid AMR assays as well. So direct from blood, there is only one FDA-approved technology, which is a magnetic resonance technology, the T2 bacteria and the T2 candida panel. There is also a T2 candida auris, which has come after this, none of which are available in India currently, though. But again, if you see the spectrum of infections that are detected here are quite narrow, and it is not good for everything that we might be looking for. The BCID panel, of course, is quite often used in our country, and this is a paper from my hospital where we use BCID extensively for escalation, if not de-escalation more often. But the faux aspect here is that you only detect organisms that are on the panel. So, for example, 31 out of our 185 positive cultures did not yield anything on the BCID because it was these organisms that you see on the right, Burkholderia pseudomel, Burkholderia species, Elizabeth Kingia, Aeromonas, etc., which are not there on the panel, and they might be missed. So it's important to know where these molecular techniques are useful and where you need to do further investigations to identify organisms. BCID panels as well as tests like the expert CARBA-R, which detect carbapenemase resistance genes, are available. Especially in the Indian setting, in an immunocompromised host, however, these tests are more useful for escalation. So if you have a resistance gene that is detected along with an organism, you would want to cover for those resistance markers. But just the absence of an organism or an AMR determinant is often doesn't help you enough to de-escalate based just on that. And that is what the SOT diagnosis consensus document in 2022 also recommends. What they do say specifically for gram positives is that you can still probably use it for de-escalation, but for gram negatives and where polymicrobial infections are suspected, they are good for escalation. And by rapid AMR detection, I'm referring to some of these tests like the direct DST from blood culture positively flagged bottles, techniques like expert CARBA-R, which can be done on positively flagged bottles, BCID. Accelerate Pheno is also an FDA-approved platform which can directly identify as well as do susceptibility from a positively flagged bottle, available in the US, not yet available in India. And you have phenotypic assays for detection of carbapenemase genes like the NG-CARBA5, etc. The next set of infections that I'm talking about are the respiratory tract infections, and these are a very important cause of graft dysfunction, especially in the lung transplant setting. And diagnosis relies heavily on nucleic acid-based testing because of the superiority of sensitivity and specificity. And it is generally recommended to be used because viral cultures are no longer easy to perform. They're kind of phased out from diagnostic labs, and nucleic acid testing is what we use. The top three viruses that are commonly seen in the transplant settings are influenza, RSV, and some of the other metapneumo and parainfluenza viruses, among which influenza RSV are the treatable causes. But of course, the other viruses are also important for in a transplant ward or ICU for infection control purposes. So it becomes important to detect many of these also. So in India, the panels that are available are the BioFire panels. We have the upper respiratory panel and the pneumonia panel. The upper respiratory panel has predominantly a lot of viruses. The pneumonia panel has both viruses as well as bacteria. And the consensus document recommends that if you are suspecting a viral pneumonia, it's where you have diffuse infiltrates, for example, on the radiology, it is good to do the upper respiratory panel. But if there is more of a bacterial suspicion because of a consolidation, etc., the pneumonia panel is probably more useful. But it's always an adjunct to conventional testing and not a sole criterion for diagnosis. It may not always be necessary to do only a multiplex assay. We do have these triplex tests which are commonly available now, which mainly look for influenza, RSV, and now SARS-CoV-2. It really depends on what is circulating in the community at the time of testing and a baseline prevalence. So the expert is one such test, and there is an Indian developed test called the Trivus, which also works quite well. I have not shown studies, but they are shown to be quite equivalent, whereas the Trivus is quite cheap compared to the expert. Problems with syndromic testing are that each of the analytes, each of the targets in the panel can have varying levels of sensitivity. And so, especially for adenovirus, there have always been concerns for the respiratory panel that it's about 85% sensitive. And you might miss out on some of the adenovirus types, even in the respiratory syndromic panels. In the immunocompromised host, of course, there is always a concern that you end up with false positives because of a past infection, because there is continued viral shedding. And this became especially important during the COVID pandemic when we saw that the SARS-CoV-2 nucleic acid would persist for a very long time. So this is another thing, this is another faux aspect, if I have to say that, with respect to PCRs for respiratory infections. This was a good review of studies which used respiratory panels in the lung transplant setting. So 4 studies included, 2 from USA and 2 from Germany. About 300 patients were studied. What they found was the panels were very useful, but also highlighted were the detections which were not found in the panel but through conventional testing. It just goes to show that they are also adjuncts to conventional testing only. For example, a lot of gram-negative rods were missed because the upper respiratory panel was used. Several of the fungi were also missed on the panels because they're not there on the panel. There were exclusive panel detections, especially with rhinovirus, enterovirus, and Haemophilus influenzae as well. The on-panel misses were more to do with one of the panels which are not available in India, so I don't think it is much of a problem for BioFire. One new technology with the BioFire is the spot fire. We know that the respiratory panel has a turnaround of about an hour, but the spot fire has a turnaround about 15 minutes. It's much shorter, so much quicker results with the spot fire. The targets are mostly similar, except that we don't have subtypes of coronaviruses and subtypes of parainfluenza viruses here. They are all detected together as one, but they have comparable positive and negative percentage agreements with the BioFire technique, except for, again, adenoviruses. Meningitis encephalitis, there are a lot of problems with the panels as such. So you generally end up having to use additional tests as appropriate, especially for cryptococcus. We know that there is enough data to suggest that the cryptococcal target is subpar. And in India, we do see quite a few post-renal transplant cryptococcuses, in which case we need to always supplement with a cryptococcal antigen, which is much more sensitive than a ME panel. PCRs for HSV, the HSV also on the panel suffers from a lower sensitivity. And toxo, of course, is not present on the panel, so you need to do additional testing like a toxo PCR or a toxo IgG. TB, which is so prevalent in our country, is not there in the ME panel, so you'll need to do other molecular tests for TB, like expert MTB. And also, even if you detect a single organism on the panel, the possibility of co-infections cannot be ruled out, especially if you find one of the latent viruses. May not always be okay to attribute the symptoms to that particular target. And we don't have AMR targets in the ME panel, and the latent viruses, of course, lead to a lot of confusion. So NGS is one modality that has been gaining a lot of traction with meningitis encephalitis, mainly because CSF is a much more easier sample to do NGS on. I mean, there are not a lot of host DNA like you would see in blood. CF is a much more easy matrix for doing NGS tests on. This is a series of case reports where useful diagnoses were made with NGS. So things like arenavirus, astrovirus, hepatitis E virus, etc. were picked up. Tick-borne encephalitis virus were picked up on NGS. Problems with NGS, of course, I will discuss in a couple of minutes. The GI panel has utility in the sense that, especially in the organ transplant setting, the negative predictive value is more useful. If you don't find anything on the GI panel and you have a gastrointestinal syndrome, it does probably show, it can lead you in the direction of a non-infectious cause. But also it's important to remember that certain targets that may be important in that symptomatology are absent. Like you don't have CMV, you don't have microsporidia, which can often cause diarrheas in the immunosuppressed host. And the non-41-42 serotypes of adenovirus are also absent in the GI panel, and therefore a disseminated adenoviral infection cannot be ruled out just by a GI panel. The turnaround time, of course, is faster. The problem is that there is a lot of false positivity with the GI panel, and this was a study which was done on asymptomatic kidney transplant recipients. So, immediately post-transplant, among the kidney transplant recipients, about 300 of them, they performed the GI panel, and 30% of them, even though they were asymptomatic, picked up something or the other on the GI panel. Especially what was detected was Clostridium difficile. So Dr. Parikshit also already said that the PCRs can be super sensitive, can detect colonizations, and they may not always show that that is the cause of the diarrhea. EPEC norovirus were also picked up in 6 and 4%. And what they found was that the patients who went on to develop diarrhea, the organism of the diarrhea did not always correlate with what was found in the initial, the asymptomatic diarrheal pathogen. And therefore, there is a high prevalence of asymptomatic colonization, which can throw you off in the wrong direction. Of course, in this study, they used frozen specimens, which may not always correlate with the fresh specimens, and the follow-up period was shorter, but it does highlight the fact that there can be a lot of false positivity. Coming to a couple of latent and reactivating infections, I won't go too deep into them, just the recent advances in these settings. CME diagnosis, of course, the pillar of care is the quantitative nucleic acid testing. And now that we do have WHO international standards, the different assays are comparable. However, it is still recommended that if you have done a CME viral load in one particular platform, you continue using the same platform for further follow-ups as well, because there can be platform-to-platform differences. There can be sample-to-sample differences also between whole blood and plasma. If CME pneumonia is suspected, doing a nucleic acid test in BAL fluid is what is recommended for improved specificity. One of the newer things that we have in this country is the CMV quantiferon assay, which is the cell-mediated immunity assay for CMV. There is not a whole lot of data in the transplant setting to suggest that it should be used or not. But it does have its use cases. For example, in the pre-transplant setting, if you have a recipient who is seropositive, it may not always indicate that they are protected. So if you do a baseline quantiferon in such patients, it indicates that the risk of developing CMV disease is lower going down after the transplant. But even in these cases, it is recommended to do a quantiferon post-transplant also. And to do a post-transplant risk assessment for 14 days after the transplant, if your CMV quantiferon is positive, it is an indicator for discontinuation of prophylaxis. Of course, not as a sole indicator, with other things as well. But if it is negative, it is definitely an indicator to continue the prophylaxis. At the end of the 3-month prophylaxis, if the R plus donor, R plus recipient is positive, it is a good indicator to stop the prophylaxis. It need not continue for 12 months, but if it is negative, it is an indicator to continue the prophylaxis. Post-treatment of CMV disease to predict relapse also, the CMI assays are useful to continue prophylaxis or not. With respect to TB, of course, India is a highly endemic country for TB, so many of the guidelines that may be there in the US may not apply so much to us because there is such a high baseline setting. What we do have are the IGRA assays. Something new that has come up is the IGRA, the TB quantiferon plus. In fact, this has replaced the quantiferon TB testing in countries like the US and Europe. In India, we continue to have both the tests available. The quantiferon plus is more sensitive in the sense that the CD8 lymphocyte response is also picked up, and therefore the window period to developing a positive interferon gamma response is shorter with the QFT plus. T-spot TB is also available. However, the South Asian transplant guideline does recognize the fact that since the country is so highly endemic, and what you do with results like that, what they recommend is that if you have a history of close contact or a past history of inadequately treated TB, either in the recipient or in the donor, the TST or IGRA may be recommended. A few aspects about fungal diagnosis. So the problem with fungi is that invasive specimens are all the time needed, and in these hosts it's really difficult to get that. Conventional techniques have very poor sensitivity, and with respect to fungi, it's very difficult to distinguish colonization versus infection. So a candida in the blood is absolutely different from a candida in the foot, for example. And DNA extraction is always a challenge with fungi because the cell walls are so thick, it's very, very difficult to get the DNA out of the fungus. And biomarkers are available, but they are subpar. Some of the newer things that are happening with respect to that is the availability of tests like fungital stat and the VACO Fujifilm assay, both of which are available in India now. So previously what we used to talk about is that you need to batch specimens when you do fungitel, so it can't be done more often than a couple of times a week. That is no longer there, and probably these tests are now more useful for an antifungal stewardship point of view because you can do them every day. But again, the problems of false positivity remain with BDG. There can be several factors that can lead to false positives like IVIGs, immunoglobulin, cellulose, medical devices, etc. Molecular diagnosis of fungal infections, as I highlighted before, the DNA extraction step itself is difficult. We don't have FDA-approved assays for fungal PCRs. We do have a few tests like aspergillus, pneumogenous, mucorgeneous available from Diagnostics. They have pretty good specificities, not such high sensitivities, but again, the colonization versus infection aspect is difficult. The European PCR initiative actually standardized many of these aspects from DNA extraction all the way to amplification and post-amplification. But the tests that we have here are not that well standardized, so you end up picking up a lot of colonizers. Even aerial spores, etc., can be picked up on the PCR assays. For pneumocystis pneumonia, even though the direct visualization by staining is the gold standard, this also suffers from very poor sensitivity, and also depends on how much, on if you have a fluorescent microscope, for example, available with you. So most of the guidelines now recommend that you do a pneumocystis pneumonia PCR along with a BDG. So both of them being positive really adds to your positive predictive value. Both of them being negative also contributes to a very high negative predictive value. And that is what the ECIL guideline says. If there is a discrepancy, however, then you have a clinical call to make. Galactomannan is not too useful in the SOT setting, especially in the serum, because patients are not typically neutropenic, and you need neutropenia for the galactomannan to be detectable enough in the blood. But BAL samples are still okay. You will have some yield, even though the sensitivity is quite poor even in BAL in the SOT setting. You have rapid assays which have reduced the turnaround times for galactomannan. The IMI and OLM are the two assays that are available in India. They have pretty shorter TATs. The IMI has much better literature support for galactomannan. And therefore, for many of these assays, it's important to incorporate them into an algorithm and not just use the test for one test for one sort of infection. So, for example, if you have PCR and ball-galactomannan available. If you do both of them, you only do that if CT suggests invasive disease, and that can avoid a lot of unnecessary testing and loss of specificity. So NGS, I briefly mentioned before, the allure of NGS is in the fact that you don't need to know what you're looking for. It is an agnostic method which is capable of comprehensive detection of multiple pathogens at one go. The Carius test is the one which is almost close to approval, I would say, in the US, which detects organisms from cell-free DNA in the plasma. It's ridiculously expensive at this point of time, but it is something to look forward to. There are very few validated standardized tests even internationally, and not a lot of literature, and there is a lot of lab-to-lab variation with NGS, and therefore results are not comparable well enough. And robust informatics are required, and that requires a lot of expertise. So to take home, nucleic acid tests contribute to reducing time to diagnosis, and often casting a wider net is important, and that's where molecular diagnostics are important. But results always need to be interpreted in the clinical context and the timing post-transplant. There are not great direct from blood or detections available at this point of time. And molecular diagnostic tests today cannot replace conventional methods and need to be always used together. And a robust diagnostic testing is something to really look forward to with the developments that are happening in that arena, that is with the next generation sequencing. So friend or foe really depends on whether we use them judiciously and guided by stewardship principles or not. Thank you.